Good afternoon, everybody. My name is Dr. Hart Beatty. I'm the chair of the APDR Education Committee and Fellowship Director for Neuroradiology at BMC, and I'd like to welcome all of you to the APDR National Virtual Noon Conference Series again this week. I mean, we are now in our 12th week of running this conference, and I'm so grateful for everybody who's attending and absolutely all the staff and speakers who have been participating in now a 3-month endeavor. So thank you all so much. As we do every week, we'll go through some of the housekeeping items. As you know, the webinar is being recorded. It is hosted on the APDR YouTube channel to be viewed on demand. Questions and comments are also being recorded during the webinar. We have muted the attendees to ensure optimal quality for the participants. And if you do have questions for our presenters, we ask that you use the question and answer tool in the Zoom platform for that. I'd like to introduce two amazing speakers and educators and just two great people who are going to be speaking today. First, we have Dr. John Pellerito, Professor of Radiology and Program Director at Northwell, and he's going to be speaking on current strategies in carotid diagnosis. And Dr. Maitray Patel will be following him, Professor of Radiology at the Mayo Clinic in Arizona, and he'll be speaking on liver Doppler tips and tricks. So without further ado, I'd like to stop sharing my screen and invite Dr. Pellerito to share his screen, and we'll be off to the races here.
Thanks again, Harp. It's great to be back. And thanks again for holding this series. I think this is great for all of our residents. So what I'd like to do is talk a little bit about our method of scanning the carotid arteries. We'll start out with our goals of cerebrovascular testing. With carotid studies, we like to define the cause of cerebral ischemic events, identify the location of carotid or vertebral disease, classify the severity of stenosis, try to determine if there's recurrence or persistence of disease, and assess for complications of therapy. So one of the most common questions that we get asked is, what's the best way to measure the carotid stenosis? And this question comes from both beginners and advanced users. And one of the reasons that this is an issue is that there are many different sets of criteria. So users want to know, which criteria should you use? Which criteria are the best? And that depends. Most sites use velocity criteria. If you review the literature, you'll see that there are variations of different velocity criteria, both in the vascular surgery and radiology journals. And depending where you work, different labs use different criteria. Now, one thing we do know is that luminal measurements don't work as well. You can see here from these images that we have on the left side a longitudinal view of the carotid artery with a small amount of plaque here, and then you can see these axial measurements where the luminal diameter is measured to try to come up with an estimated stenosis that is thought to be about 64%. But you got to recognize that unlike CT and MR, luminal measurements on ultrasound are not well validated. And there are no current accreditation strategies that endorse these types of luminal measurements. And in fact, just to show an example, in this case, taking an off-axis luminal measurement gives estimation of 64% stenosis. And if you look at the duplex exam, where we have a peak systolic velocity of about 70 centimeters per second at the same level, we get a completely different estimation, which would be less than 50% stenosis. So duplex measurements provide better correlation with arteriography than luminal measurements, and we don't support luminal measurements in our practice. So here's a study that Grant had done some years ago and shows you there's just a whole bunch of different thresholds that are out there that have been published to try to identify ICA stenosis. And you can see that there are different levels of stenosis from 50 to 70%, different peak systolic velocity thresholds, as well as end diastolic velocities and ratios, all with different sensitivities and specificities. So a lot of different criteria out there. And of course, then we have the Society of Radiologists and Ultrasound consensus criteria, which many radiology groups use. And you can see here that we break it down into essentially 4 categories to try to classify stenosis. And we'll come back to this. Now, the ICAVL, the Intersocietal Commission for the Accreditation of Vascular Labs, did a survey trying to find out what different labs use. And these are labs in cardiology, vascular surgery, radiology, and you'll see that there's a mix of different criteria. But the majority use the SRU-based criteria. And that's what we use. And I think it's important to recognize the differences. So let me show this case. Here's a 68-year-old with syncope. And you can see on the grayscale image here, there's this heterogeneous plaque, partially calcified, partially soft plaque, narrowing the lumen. Turn the color on, and you can clearly see that there's a narrowed lumen with some aliasing. Here's the jet of the stenosis. And if we sample that, we get a velocity of peak systolic velocity of 240 centimeters per second. So what does that translate? What is the degree of stenosis? Well, that depends on which criteria you use. If you use the classic University of Washington criteria, that would be about a 50 to 79% stenosis. By SRU criteria, velocity of 240 is greater than 70% stenosis. Mineta from the vascular surgery world would classify this as less than 60%, and Bluth would make it 60 to 79%. So you could see here, there's a great variability in something that's considered either close to 80% or less than 60%, depending on the criteria. So again, getting back to the question, which criteria are best? Well, it depends. There's a lot of variables. Depends on your protocol. Depends on how your sonographers are trained. You have to use angle correction. How do you use angle correction? Is everything done at 60 degrees or not? It depends on your equipment and your patient population. So how do you choose? Well, you know, you can work out different sets of criteria and see which correlate best with your imaging studies, or you can start with the SRU consensus criteria, which is what most groups do. So getting back to the SRU criteria, you can see here the degree of stenosis is broken down into normal less than 50%, 50 to 69%, or greater than 70%, with near occlusion and total occlusion being those other categories. And the primary parameters are the peak systolic velocity in the stenosis and the presence of plaque. The secondary parameters can be helpful, and that's the ICA-CCA ratio. That's the velocity in the stenosis compared to the distal common carotid artery, and the end diastolic velocity in the ICA. So it's important to recognize that those primary parameters, the peak systolic velocity in the ICA and the stenosis, and the presence of plaque, work really well for grading stenosis by themselves in general. But when you have unusual cases with either high or low flow states, that's when the ratio and the end diastolic velocity can be very helpful, and we consider them as important secondary criteria. Here are a couple of studies that were done to evaluate the SRU criteria. And it's important to recognize that these consensus criteria came from no specific research study. This came from a consensus panel that was held in San Francisco, where we basically all sat down and agreed on what we thought were appropriate cutoffs. So it comes from no research exam, basically just a consensus. And these guys who looked at these criteria in their practice found that the criteria had good sensitivity, but did not have the specificity. And so that's where the issues come up with using these criteria. So remembering that the criteria are from a consensus statement, and we also should recognize that these criteria are only intended for measuring ICA stenosis at or just beyond the bifurcation. Not in the common, not in the vertebral, not anywhere else. It's just intended for the ICA stenosis near the bif. So it has its known limitations. And the other issue about the SRU consensus criteria is it doesn't include waveform analysis and post-stenotic changes, which I think are very important, something you should be looking at. So it's interesting to know that the IAC, the Intersocietal Accreditation Commission, which accredits vascular laboratories throughout the country, has recently done a reappraisal of the accuracy of these consensus criteria. And basically what was done, and I'm on the board of IAC, We basically took a bunch of carotid duplex studies from a number of labs around the country and compared them with catheter DSA, and making specific recommendations on these diagnostic criteria. And this paper is about to be published. I can give you a preview. And we found that there was only moderate agreement between ultrasound and catheter angiography. We found that the SRU consensus criteria overcalls less than 50% and 50 to 69% stenosis. And so we are going to recommend increasing the peak systolic velocity cutoff for those moderate lesions. But we found that there was fairly good agreement for those high-grade lesions greater than 70%. So those won't be adjusted too much. So that the revised criteria that will come out of this project will be slightly different from the current SRU criteria. And I'm sure they will also go through rounds of testing in different practices. So just a brief review here. To recognize normal waveforms, we have to remember that in the ICA, because that vessel is feeding the brain, that we expect to see continuous forward flow in systole and diastole. There should be a high systolic and diastolic flow because the brain demands continuous flow throughout the cardiac cycle. The ECA, on the other hand, only supplies the skin and the muscle of the face and neck, so we have much less flow in diastole and helps us to distinguish the waveforms as coming from either the ICA or the ECA, depending on the waveform shape. The common carotid, on the other hand, is a combination of two as it's feeding both of those vessels. So we see a mix of those two different waveforms. Now, the way I see the examination is that it combines three different parts of the carotid exam. We look at the grayscale for presence or absence of plaque. And when we look at the plaque, we try to describe it as soft or calcified or a combination of both of those. We turn the color on to look at the flow dynamics. Is it laminar flow or is it disturbed turbulent flow? And that can be very helpful to show us where the stenoses occur. And that's why color is so important when we do these studies. And of course, we integrate spectral analysis, which allows us to determine the degree of stenosis. So we place the sample volume in the area of interest, making sure that we angle correct to the direction of flow, which many times we default to 60 degrees, right? That's as high as we can go with our angle correction. But the key here, of course, is making sure we're aligned with the direction of blood flow, which would then allow us to determine the peak systolic velocity in that segment of the carotid artery. So here's an example. Here's an 80-year-old who presents with extremity weakness. And you can see here from the color video that as we get into the proximal internal carotid artery, there's a very tight stenosis. And we can see irregularity, narrowing, and aliasing. So we know where to place the sample volume to get the highest peak systolic velocity. And we do that here, and we can see the velocity is very high, 678 centimeters per second, consistent with a high-grade stenosis. And in fact, the end diastolic velocity as well is pretty high. So it's important to recognize there's a whole constellation of findings that occur here. As you drag that sample volume through the pre-stenotic segment into the stenosis, into the post-stenotic area, we're going to see significant changes in the waveform pattern. In the pre-stenotic segment, notice here on the top, low velocity, high resistance. All those red blood cells are trying to squeeze through that tiny narrowed segment, like cars on a thruway getting blocked up when there's an accident. And then they'll be able to speed up as they move through the stenosis. And then as they move further downstream, as that vessel opens up, we have red blood cells moving in different directions at different velocities, providing this very turbulent pattern. You can see with a bidirectional signal. Some red blood cells are going toward the probe, some away from the probe, all the different velocities. That disturbed pattern is very consistent with a significant stenosis. And as we get downstream, you'll see that we start to reorganize, right? We have that low velocity, high resistance pre-stenotic signal, high velocity as we move into the stenosis, turbulent flow as we get out of the stenosis, and then downstream, we're going to see these rounded waveforms with that sort of a mountaintop appearance, which we call tardus parvus, right? And tardus parvus means it's a post-stenotic signal or waveform downstream from a significant stenosis. So looking at this constellation of findings, it's very helpful for us to use these to characterize a significant stenosis. So here, just to summarize, right? The waveform features that are consistent with a severe stenosis: high velocity in the stenosis, turbulent flow distal to it, and tardus parvus waveforms downstream. And this is very helpful because in addition to seeing high velocities, when we do these studies, by adding on these waveform appearances, we can be very certain when we have a severe stenosis. So I consider carotid interpretation a fairly sophisticated process where we're looking at multiple things, not just the velocity, right? We're going to look at the color and power display, obviously showing us where the abnormal flow is, where there's narrowing. We'll look at both the systolic and diastolic velocities. We'll integrate in our head the velocity ratios, and we'll do waveform analysis. Now, why is velocity measurement alone not good enough? Well, there's a lot of variables, and patient age is one of them, right? Young patients have high velocities, which don't follow the rules. They don't follow the criteria. We can have evidence of inflow and outflow obstruction, which I'll show you, which change velocity measurements. Contralateral carotid stenosis will increase blood flow on the side opposite a high-grade stenosis or occlusion. Carotid artery tortuosity will change velocity measurements because you can't angle correct appropriately around a turn or a twist. Cardiac disease can increase or decrease velocities depending on whether there's a cardiomyopathy or an aortic stenosis. And near total occlusion, as I'll show you, can also change velocities. Let's take a look at this case. So this is interesting. This is a recent case. 84-year-old presents pre-op for TAVR, looking at the right carotid artery. Now, here we're looking at the right side. And again, there's all this calcified plaque. There's the shadow. And you can see marked narrowing and aliasing there. So we place the sample volume in the stenosis, angle correct to the direction of flow. And we see the velocities over 500 centimeters per second. Again, like the other case, consistent with a high-grade stenosis. Now look at the left side. Left side, the color display, nice homogeneous color pattern. Sample volume correctly placed in the middle, angle corrected. Velocity is only 65 to 80 centimeters per second in that internal carotid. Look at the waveform shape. Nice low resistance pattern. Here's our upstroke, lots of forward diastolic flow. So it looks pretty good, right? So the problem is clearly on the right high-grade stenosis. Patient comes back after the TAVR. A couple of days later, altered mental status, right? Looking at doing a repeat study, we're looking at the right side. Again, the stenosis is still there, and I'm showing you the tardus parvus waveforms downstream. Again, nothing changed on the right, but let's look at the left. The left is still wide open, right? The color display shows a nice homogeneous pattern, no evidence of narrowing, but look at the waveform. It's changed. Very high resistance. Where's the diastolic flow? Doesn't exist. There's actually a reversal early in diastole and no flow. What happened? Well, hard to tell just from the grayscale or color Doppler images, as the vessel still looks okay. But something has changed. We now know because there's no diastolic flow, something must have happened downstream. There's a blockage that is outside our field of view. So we ordered the CT angiogram, and the CT angiogram shows that there is thrombosis of the distal left carotid artery. The arrow shows that there's absence of enhancement in that vessel. So it's clotted. Now, whether it's from just an embolization of thrombus or a dissection, I can't tell from this scan. But clearly there's a blockage there that we picked up solely from the waveform. So it's always important not only just to look at the velocities, but look at the waveform shape. And here is a striking example of a change that occurred because there's distal thrombosis. Now, here's a 78-year-old with a history of carotid disease. And of course, the color display is abnormal. You can see that there's marked thinning, tapering. It almost looks like it stops, right? You don't actually see continuity of the vessel. And the velocity is only 37 centimeters per second. So what's going on here? Is it an occlusion? Is it a very tight stenosis with a very low velocity? Kind of hard to tell. And so this patient also went on for a CT angiogram, and you can see there's a very, very tight stenosis of that distal ICA, which you can see very well here. The right side was fine, but the left side is what we call a near occlusion. And it's interesting to note that when you have a very, very tight stenosis, you can have low velocity. So the issues with a near occlusion is that it can be confused with a total occlusion because it's hard to see the residual lumen when it's so thin. And it may not be seen in up to 30% of cases. 75% will have a focal high-grade appearance. 25% will have severe diffuse narrowing, which looks like the so-called string sign, and may be the result of a chronic dissection. And that peak systolic velocity can be in the low, normal, or moderate range. And this can be a problem as it may be a source of emboli and TIAs. So how do you explain that? Well, if you look at the classic Spencer-Reid curve, you see that in general, the velocity, which is the blue line, will increase with increasing severity of stenosis to a point. And as we get into very, very tight, critical, near-occlusive states, the velocity actually drops off and can be very low, as we have in that case I just showed you, which corresponds with the flow pattern. The flow pattern is relatively constant till we get to about a 70% stenosis, and then it starts to drop off and gets very, very low as we get to very severe tight stenoses. So recognize that, as you see in this blue line, that you can have a pretty tight stenosis and a relatively low velocity. ICA occlusion, obviously, will see no flow in the vessel, and you can see it's either filled with plaque or thrombus, and you'll get no flow on your duplex display. Typically, there'll be high resistance waveforms in the common carotid because all the blood flow is diverted into the external carotid artery. And your ability to be confident with ICA occlusion on duplex ultrasound depends on how well you see the vessel. When you see it as well as we see here and can sample through it, you can be pretty confident. But if you're not seeing it well, then you really need to go on to a correlative study. So accurate diagnosis relies on appropriate instrumentation, optimization of your grayscale and Doppler parameters, comfortable with your criteria, which you validated with some internal testing, including waveform analysis and integration of all of those diagnostic features, right? The velocity, the color appearance, using ratios as well as waveforms. So I'm going to finish up with, in my last 5 minutes, talking about some of the newer things that are coming out, which are going to impact on our ability to improve carotid diagnosis with ultrasound. One of them is relatively been around, is the carotid plaque characterization using and looking at IMT, but now we add stiffness to that study, which is interesting. I'll talk a little bit about ultrasound contrast imaging, as well as vector flow imaging and volume flow measurements. So as I mentioned, intimate media thickening has been around. Cardiologists have been using this for over a decade. It's basically measuring that first line that we see here. You know, the intima is really a combination of the intima and the media. And, you know, it can be measurable and certainly gets thick with atherosclerotic disease. The problem that we've had is accurate reproducible measurements. We know it's important because not only is the intimamedial thickness a marker for atherosclerotic disease, it predicts risk for future cardiovascular events. And that's why our cardiologists are tracking it and measuring it. But it has been difficult to get reproducible measurements. People do it differently and they measure in different places. So it's not unusual to get disparate measurements from examiner to examiner, location to location. But new techniques are now using RF data to do this measurement automatically and getting more accurate IMT measurements than using grayscale or B mode alone. So this is something that is relatively new on our instruments, and it can be used for those who like to track IMT. Something that is relatively new is stiffness quantification. We know that normal arteries are compliant. They change with arterial pulsation. And as aging diseased vessels get stiffer, they lose their compliance and elasticity. And this is also a predictor of cardiovascular events. Newer software that we now have on our instruments is able to track changes in vessel distensibility, give us a better indicator of stiffness and a degree of atherosclerotic change. So relatively new modality, but something that can be very useful in assessing changes in vessel wall thickening and seeing how patients respond to intervention and treatment. Another relatively new technique is vector flow mapping. And as you see here, we can pretty easily track the movement of red blood cells. And as you can see, as we move across the stenosis, how the red blood cells move direction, move velocity. This technique combines frequency, phase, and amplitude changes to be able to display pretty complex hemodynamic states. It can help us to improve velocity estimation and flow directionality. And the hope is that in a short time, we'll be able to use these 3D vector fields to be able to calculate volume flow without needing to go to Doppler measurements, so that they would be more reproducible and more accurate in being able to determine velocity and degree of stenosis. And finally, just a few words about ultrasound contrast. Again, ultrasound contrast has been around. We know it's FDA approved for liver imaging, pediatric imaging, and much of what we do is off-label. Particularly a lot of the studies that I do in the vascular lab where I'm using ultrasound contrast is done off-label, and I typically will get consent. Well, what we have found and what studies have shown is that the addition of ultrasound contrast can improve the detection of near total and complete occlusion. And it is used for so-called Doppler rescue studies. The duplex study or the color Doppler study is inconclusive, may not see the vessel wall. For example, here, we have a study of the carotid bifurcation. We see blood flow in the bulb, but we don't see any flow in the ICA. And so the conclusion might be that this is an internal carotid artery occlusion based on the color Doppler study alone. But we see in this case that by injecting ultrasound contrast intravenously, we're able to demonstrate that there is a near complete occlusion, a so-called string sign, in the ICA. So it is not completely occluded and may be amenable to revascularization. Whereas if we say that this is a completely occluded vessel, that option does not exist. So we're starting to get more comfortable using ultrasound contrast for these vascular applications. We're finding that there is a good correlation between ultrasound contrast studies and arteriography for stenosis grading, and I expect that we'll be using this more in the future. We've also seen studies that have shown the use of ultrasound contrast in plaque detection. And you can see here two examples of studies of the carotid artery following the administration of ultrasound contrast. And the arrows point to these areas of neovascularization in the plaque. And the more intraplaque vascularity we see, the more we are concerned that these are vulnerable plaques, prone to ulceration, prone to embolization. And again, these studies may be very helpful in determining how to treat these patients. So I'll finish here. We've talked about the different ways that we can interpret these studies by integrating a number of different parameters. Doppler studies require optimization, right? You need to be able to see the vessel well. You need to be able to fine tune your color and pulse Doppler so that we get information that is accurate for diagnosis. We want to integrate not only the velocity information, but also integrate waveform analysis, because I really think that allows you to make most accurate diagnosis for carotid studies. And recognize that there are new 3D and ultrasound contrast strategies we'll be using in the future to improve diagnostic accuracy. Thank you all. Thank you, Harp. Hope everyone's doing well, and appreciate your time.
John, thanks so much. Really, really great talk. Really appreciate that. I'll have you stop sharing your screen then, and I'll invite Dr. Patel to begin his session.
All right, well, let's kick it off. We'll go through some liver Doppler and its tips and tricks, and tips is all capitalized because we're going to talk a little bit about transjugular intrahepatic portosystemic shunts. Have nothing to disclose other than the fact that I tend to speak fast, and I'm really going to go fast in this lecture because I want to show you lots of examples, and this is recorded, so you can go back to review items. That's the beauty of recording. So our objectives here, we're going to look at how to evaluate TIPS shunts, and then after that, we're going to look at some tricky cases with respect to the portal vein, and some tricky clinical scenarios where I think sometimes people aren't looking at the right things or they're overestimating what they're looking at. So TIPS, everybody's familiar with TIPS, transjugular intrahepatic portosystemic shunt, and I'm not Netter, but you can see my little diagram here where I'm showing you the TIPS that's drawn in, and basically it usually extends, not always, but usually extends from the right hepatic vein down to the right portal vein. Now, TIPS used to be bare metal, but now they're covered with PTFE, and that does make a difference in terms of what we're seeing. Covered stents have less TIPS dysfunction. Couple of theories around that, no bile contamination into the TIPS, and so that's thought to help because bile is thrombogenic. And for whatever reason, there's reduced pseudointimal hyperplasia. But even so, with covered TIPS, 20% of TIPS patients will have a dysfunction of their TIPS within 2 years. So how do these shunts go bad? Again, not the greatest drawing in the world, but you can see that with bare metal stents, there were 3 ways things went bad. There could be a stenosis at the hepatic vein interface, usually because when we put in these TIPS, at least in the initial periods when we were putting them in, we wouldn't go far enough. And so there'd always be a little bit of a bare area at the end, and that was a setup for a stenosis. But there would also be a possibility of pseudointimal hyperplasia causing just general narrowing of the TIPS. And finally, because of that thrombogenic bile, we oftentimes would get focal stenosis, even in the mid or proximal TIPS due to focal thrombus there. With the covered stents, quite frankly, the stenoses we see are almost always at that hepatic vein interface. So what do we do when we assess TIPS on ultrasound? There are 7 areas or 7 things we're going to look for. And so the sonographers at our institution look carefully at all these. First, we're going to measure the direction of flow and the velocity at the main portal vein before the TIPS. Then we're going to assess the direction of flow in the liver, not related to the TIPS, but the intrahepatic left and right portal vein. Let me put a laser pointer here, okay. We're going to measure the velocity of the TIPS in 3 areas. Proximally, sometimes this is even within the portal vein itself, in the mid-TIPS, and then distally at the hepatic vein interface. And then finally, we're going to assess the ascites, because that can be an indirect clue that can be helpful. All right, so let's look at these parameters and what we're looking for. First, for the main portal velocity, quite frankly, I've recently, meaning the last few years, been turned on to this. I've been looking at TIPS for my whole career, but this wasn't something that I was sort of tuned into, but the velocity is helpful. So the main portal velocity, if it's less than 30 centimeters per second in the main part of the portal vein before we get to the TIPS, that's not as good. We don't want to see that. And then the direction of flow in the left and right portal veins is helpful, especially if you have a baseline study showing that it was completely decompressed by the TIPS. So if we're following a TIPS over time and we want to see if it's narrowing out and not functioning as well, if previously the portal veins had flow that was, hepatofugal, meaning, it was going this way. Let me see if I can draw on this. Okay. So if it was going this way, again, I'm not a great drawer, but previously it was hepatofugal, and now, over time, it's hepatopedal, meaning going the other way, like that. Then that implies that there's that narrowing here in this TIPS that's backing up flow and causing less decompression of the portal flow. Okay, go to the next slide here. All right, and then the peak systolic, the peak velocity within the tips is another factor, and we like it to be we'd like it to be over 90 to 100 centimeters per second. If it's less than 50 to 60 centimeters per second in our shop, we recommend a tipsogram. So what we do is if it's less than 90 to 100 centimeters per second, we'll get a follow-up tips study, an ultrasound study, in less of an interval than we ordinarily would have done. So if we were doing 1-year interval follow-ups on a patient and we see that the velocity is 90 or 80, then we'll say, you know what, the next one, once you get in 6 months, not a year. Whereas if it's less than 50 to 60 centimeters per second, we'll send them to the IR suite for a tipsogram. Not that day, but within a short period of time. And then finally, obviously, the ascites. If the ascites is getting better, that's good. If the ascites is getting worse, that's bad. Okay, so let's look at 10 cases because I think it's just useful to look at that. Actually, I didn't want to do that. Let me get out of that. Sorry about that. Okay, so first case. And these images are a little small, so I'm going to zoom up on them as we need to. But here we got the tips is patent, as you can see. But the velocity is 64 centimeters per second in the tips. It's hepatofugal, meaning we are essentially draining the fluid away. You can see in the right portal vein here, we're going away from the anterior segment of the right portal vein. So that's good. Here in the left portal vein, it is also draining away. And so that is good. Everything's, is over 30 centimeters per second. Everything's draining away. And then when we look at the velocity within the tips itself, it's over 100. So 135 in the proximal part, 182 towards the hepatic venous side, 103. Everything's looking good. That's a normal tips. Okay, case 2. Here we go. Main portal vein 48. That's good. It's greater than 30. We're not going to stop there, though. The right portal vein, we're not seeing flow very well. Maybe there's a little bit, probably is here, but it's going below the baseline, so it's going away. Here on the left portal vein, the flow is not well seen at all. In fact, we're not seeing it. The tips, here is patent. Proximally, it has a high velocity, 240. In the mid-tips, it's 133. And the distal tips, it's 143. So the velocity is high. It's above that 100 centimeters per second threshold that we were worried about. I'm not that worried that the velocity is really high proximally because, and we'll look at that in a bit. But the bottom line here is that you might be concerned about the fact that you're not seeing flow in the portal veins. But it turns out that that's okay. The best way to describe this absent intrahepatic portal venous flow is to say that if you don't see the veins as distended structures, if you're not really seeing the veins at all, then what I recommend is you say the intrahepatic right and left portal veins are decompressed without demonstrable flow. If you see the veins, this is usually true on the left, and it's not, you're not seeing flow, but it doesn't have echoes within it, then say intrahepatic right and left portal veins are stagnant without demonstrable flow. And if you see that the veins are distended, or if they are normal caliber and they have echoes, then you say they're thrombosed. Because I think people get freaked out if you talk about thrombosis of intrahepatic portal veins, when really we commonly see stagnant flow within the portal veins after putting in the tips. So for example, and again, this is what we do, and you'll have to correlate with the people that you work with. But if I saw a case like this where the left portal vein here is hypoechoic, and I can't really demonstrate great flow, when the sonographer really turns up the gain, he or she can get sort of maybe bidirectional but really sluggish flow. I'm not going to say that this is thrombosed. I'm not going to say that this is decompressed because I can see the vein. I'm going to say that it's stagnant. Okay, let's turn our attention to this case, and I think we're going to have to blow up on these. So first, we're looking at the left portal vein here. It's hepatopetal. The right portal vein is hepatopetal. So that's not what we want on the tips generally. Here, the velocity is 33 centimeters per second. So it's not bad, but it's not as good as we've seen. And then in the tips, it's 47 centimeters per second in the mid portion of the tips. That's less than my 50, so I'm going to send this person to the IR suite. And in fact, at the right hepatic vein end, it gets higher. It gets much higher at 234. So we see the actual narrowing. Now, it turns out that you don't always get to see this actual narrowing of the distal part of the tips. And so that's why we need to rely on the mid part of the tips velocity to sometimes clue us in. But in this case, it's a slam dunk. This is a narrowing at the distal tips, and sure enough, the patient had a stenosis. Okay, case 4. Now this is a QA case. So here we go, left portal vein, it's kind of bidirectional, not really seeing it well, so I'm gonna say it's stagnant. The tips is open here. The tips is patent. It's got 62 centimeters per second. That's pretty good. We go to the proximal tips, 74, mid tips, 135, distal tips, 152. Remember, my number was 100 centimeters per second. So ordinarily, I would not have called anything wrong with this. But the person who read this out said, hey, I'm a little worried because the tips goes from 75 to 140. And I know from hemodynamic principles that if there's a doubling of the velocity, that sometimes that corresponds to a 50% reduction in the velocity. And so they talked about a stenosis. But you can't use that in the tips where you see that the velocity just gets progressively higher towards the end. That's not a jet effect. And so we need to understand what the jet effect features are. So when we talk about a jet effect zone, what we're talking about is the fact that you have a high velocity at the area of narrowing. It generally goes away downstream, and then you have an abnormally low velocity leading up to that high area of narrowing. And so the jet effect is to have both of these. In that last case, we did not see both of those. Okay, so let's go to this case, case 5 QA. Here we've got the tips. It's the right portal vein is fugal, left portal vein is fugal. It's a really weird waveform, but that's okay. We're going to talk about that in a bit, but it's definitely being drained away. So that's good. We look at the velocity here. It's 180 proximally. It's 270 in the mid tips. It's 360 in the distal tips. It's actually pretty high. But again, in my shop, we're not going to call this a stenosis. If anything, it might benefit from being upsized because the whole thing's probably too narrow for the amount of flow that's going through here. But it's not a dysfunction of the tips itself. And the fact that it actually is decompressing flow, as we saw in the previous image, suggests that it's nothing to worry about. Okay, but unfortunately, I didn't read this case, and so this person said, hey, the velocity gets too high, and I'm worried about a stenosis. But there's no jet effect, so we should not agree with that. Okay, next case. Here's our tips. It's patent, but it's not decompressing flow. Right portal vein is pedal, left portal vein is pedal. It's going towards the transducer, so it's not decompressing the flow. Let's look at the tips. The velocity here is 27. Oops, that's too low, less than 30. We go to the mid portion of the tips at 61, not my 90 to 100 number, so I've got another nail in the coffin here. I'm not happy with it. It is over 50, but this velocity is not good, and it's not decompressing the flow. And if we go up higher, sure enough, at the distal end of the tips, we see a jet effect zone. It's getting much higher at that distal area and lower in front of that. And so therefore, this is one to worry about. And sure enough, here's the angiogram and shows you a nice little stenosis that they treated. Okay, case 8, here we go. Main portal vein, 50 centimeters per second. That is fine, right? It's greater than 30. The tips at the portal vein, approximately 128, goes up to 114, or actually goes down to 115, so no meaningful change. And at the IVC, it's 115. So it's above 100, not that worried. So far, everything's looking good. Right portal vein is being drained away. That's great. Left portal vein, what? It's going towards the transducer. So it is hepatopetal, not hepatofugal. Why would this be? And just keep your thinking caps on. Why would you have hepatopetal flow in the left portal vein, but hepatofugal flow in the right portal vein? It's because there's another shunt coming out this way. In fact, you want to look for that recanalized paraumbilical vein here, which is patent. And so this TIPS could benefit from upsizing because it is not completely decompressing flow in the liver, even though the right right liver is being decompressed and it's still going through the tips, it could be a little bit bigger for effective function. All right, case 9, here we go. TIPS approximately is 51 centimeters per second. It's getting close to my 50, and I'm not that happy with this. 63, 71, so it's generally pretty low within the TIPS. Left portal vein, it's not decompressed. Right portal vein, it's not decompressed. So this looks like, you know, a worrisome case, but it's not less than 50, so should we just have her come back in, you know, 6 months instead of a year? Or 3 months if we were doing 6-month follow-up? And the answer is always remember to look at the previous study. And so in the previous study, the velocity was much higher, 140, 145, 133. So we don't need to wait in this case. This patient should go to the angio suite for a TIPSogram. And in fact, previously, the patient had hepatofugal flow in the left and right portal vein. So there was a change in the direction of flow. That's another nail in the coffin for this person to go and get an angiogram. All right, case 10. TIPS was placed earlier in the day and they want to get a baseline. So here we go. Here's the velocity, 48 centimeters per second in the main portal vein. Coming down to the left portal vein, it's fugal, it's going away. Right portal vein, it's fugal, it's going away. So far, everything's looking good. But when we go to the next image, you can see that the portal vein velocity in the TIPS, it's really high proximally, and then we just don't see it. So what's going on? Is it occluded? Are we worried? And the answer here is just to remember that you can't look at these TIPS with ultrasound right when they put them in, especially if they're, particularly if they're covered, because they get air in the interstices of the covering, and so that basically shadows out the TIPS. So you don't have a chance to actually see flow within the TIPS on day 1, and you have to sort of use these indirect measures to see how things are going. Okay, so proper use of these metrics should assist you in correct management of TIPS patients. Now let's turn to the tricks. We're going to look at another 10 cases, but now we're going to look at portal vein abnormalities. Here is a case where the main portal vein is blue, it's going away. The spectral waveform shows it's below the baseline. Here, the right portal vein anteriorly, it's going away. Left portal vein, it's going away. So no, not that tricky here. This is a first-year case. Basically, this is just hepatofugal flow in the main portal vein. Big deal. All right, but sometimes we'll see this. Here's the main portal vein. It's kind of capacious. And here in this part of the main portal vein, we're getting flow that's going away. It's going down. But then in this part of the main portal vein, it's going towards the transducer. So this is really bizarre if you don't recognize it. And what you need to recognize is that there's spiral or helical flow in this main portal vein. And it's not that common in patients who are not intervened upon, but if the patient has had a liver transplant, is really common. If the patient has a TIPS in place, it can also be seen. So don't be confused by helical flow in the Doppler vein, in the portal vein. It'll show you both hepatopedal and hepatofugal flow within the main portal vein. Okay, here's case 13. Splenic vein coming across, it's abnormal, right? It's hypoechoic compared to the surrounding mesenteric fat, but it also has some echoes in there. We see a little bit of flow here, but not here. It's distended, and again, there's echoes. But I show you this part of this case because it is okay, not okay, it is natural for the main portal vein, that is thrombosed, to be hypoechoic when compared to mesenteric fat. But when you look at it compared to the liver, it tends to be isoechoic to the liver. And this is going to be an important point because a thrombosed portal vein tends to have echoes in it and tends to be about as echogenic or not much less echogenic than the liver. And here's the CT showing that the patient had portal vein thrombosis. And why am I showing you this case? Well, take a look at this case. Here's a case where we're in the liver. Here's the main portal vein. We can't, for the life of us, get flow in this thing with spectral or color Doppler, but it just looks really hypoechoic. And Patel just told me that it should be isoechoic to the liver if it's thrombosed. So I'm not confident that this is thrombosed. This is a common cause of mistake that people will make, is overcalling portal vein thrombosis when it's really hypoechoic, but you just can't demonstrate color flow, despite optimizing your technique. And so in this case, again, I didn't read this out, but somebody said, you know what, we're worried about thrombosis. The next day, a different sonographer went up. This was done in the evening. The next morning, somebody went up because this is going to be really important for this liver transplant patient, pre-liver transplant patient. And sure enough, using a different transducer and maybe a little bit better angle correction or angle incination, they were able to show flow. So you want to be suspicious of calling portal vein thrombosis when the portal vein is really hypoechoic compared to the liver. The portal vein, when it's thrombosed, tends to be as echogenic as the liver. And this scenario where it's hypoechoic should make you think that you might be being tricked. What are some things you can do? Well, first thing is to look downstream for Doppler signals. So basically, here this patient has liver disease. It's a hypoechoic portal vein. We cannot, for the life of us, get spectral or Doppler flow here. Well, one trick is there flow in the left portal vein up towards the liver capsule? So we go up there, and sure enough, this patient has so much liver disease that they have a recanalized periumbilical vein, and it's going from the liver out. Well, there's no way that this flow could get to this point going away from the liver if the main portal vein is thrombosed. And so you know that the main portal vein must not be thrombosed. And so here, this should not be in your report. You shouldn't say that you're worried about portal vein thrombosis, but then at the same time, there's a periumbilical venous collateral that's identified. That just makes no sense. Okay, and the next day, the CT was done, and it showed that there was portal vein flow. So if you're really in doubt, you can look at the surface of the liver, but also you can use contrast. And so here you can see a dilated hepatic vein, hepatic artery. We've really upped the color signal on this. We're bleeding out all our color. Here the vein is, hypoechoic, really hypoechoic, and we can't find any color Doppler flow in here. So we did a contrast study. You can see here this portal vein, which is hypoechoic compared to the liver, on this image that's got the low mechanical index, basically filled with flow with the contrast. By the way, that's at the same time. These are dual images, so it's not later. This is at the same time. All right, case 17, here we go. Main portal vein, it's distended, it's got echoes. There's something wrong here. But when we put Doppler on, there are some blips of flow. Is this recanalized flow? Always remember, you need spectral. So when we put spectral Doppler on this, this, unfortunately, is a patient who has arterialized flow within the portal vein that's thrombosed. And so this is tumor thrombus and something you want to recognize. Another tricky case. Here we go. Here's the portal vein. It doesn't look like a normal channel. In fact, it's got lots of different dots. And we are able to see that there is some portal venous flow. And so this is a cavernous transformation case. Cavernous transformation of the portal vein. Another case here, case 19, of cavernous transformation, where the portal vein doesn't look as much like multiple channels. It looks like one channel here, but the gallbladder wall has all these varices. So you only really get gallbladder wall varices in the setting of a patient who has had portal vein thrombosis. That's when these things get collateralized. And in this case, the patient eventually developed recanalized, not recanalized, but collateral, so cavernous transformation of the portal vein. And that's what this is. Okay, case 20, here we go. Here's the right pleural effusion, right kidney, liver. Looks weird, lots of echoes. There's spot, dot, dot, dot. And you're gonna take a look at this. This is the waveform in the main portal vein, and you can see that it's going the right direction, but you see occasionally these little blips, even better demonstrated here in the left portal vein, these little blips of spikes. And if I take a look at the, let me get off of this laser. I don't know why this cine's not working. I think it's because I'm on my laser. Let me get off of that. Okay, yeah, here we go. And you can see that in that portal vein, you see these little blips coming through. And so this is air within the portal vein. So a tricky case, but nicely demonstrated with that cine. Okay, another case. Actually, this is that same case, right pleural effusion. Here's the the liver with the multiple echoes, but then on the follow-up study the next day, those echoes were gone, and this can be a transient finding, and it was in this case. Here's another companion case. If we take a look at this, you can see that there's lots of echoes within the parenchyma, as we've seen on the still. And if you look at the portal vein carefully here, you'll see these little things coming through. Put a spectral Doppler on, you'll see these little spikes. They did a CT 2 hours later. They didn't see gas in the portal vein. They didn't see any air in the liver. And they said, you guys were wrong. But we were not wrong. This thing can go away, and it can go away, within a couple of hours. So this is a very transient phenomenon for some patients. So our objectives today were to look at tips and to recognize some tricks. There's two clinical scenarios I want to leave you with that can be confusing, that I want to make sure you never get wrong. And so first, congestive hepatopathy. Here's the portal vein. Has a really bizarre waveform, very pulsatile, above and below the baseline. This can be seen with cirrhosis, but more commonly what you want to do is look for some other features of congestive hepatopathy. Well, what might those features be? Well, we see that the hepatic veins are really dilated, and also the hepatic veins are quite pulsatile. It's normal for the hepatic veins to have pulsatility, but this is a lot of pulsatility, and you can see here that the IVC is pretty distended. So this is a perfect case of congestive hepatopathy, and you just want to nail that in your report. The other thing I want to leave you with is this thing, hepatic sinusoidal obstruction syndrome, because I see people getting this wrong all the time. It's also known as veno-occlusive disease. This is something that happens in patients who are undergoing bone marrow transplant or hematopoietic cell transplant. They have a particular set of clinical findings of right upper quadrant pain, hepatomegaly, jaundice, ascites, but not all the clinical features can be present or may be present. Their LFTs are usually up, their bilirubin's up. It's oftentimes at a particular time point within the first 3 weeks of the bone marrow transplant, and it's very common, or more common in children than adults. There are some risk factors for this, pre-existing liver disease being the main one, and it resembles Budd-Chiari clinically, but it has nothing to do with Budd-Chiari on the exam in terms of the ultrasound. So in the imaging findings, you're not going to be able to make this diagnosis, but you're going to be able to support it. And what you want to look for is ascites and a really thick gallbladder wall. You can also look for increased resistance to flow in the liver. Remember, the sinusoids are obstructed, and so there can be a high RI. There can be an abnormal portal vein waveform, which is sluggish. But the hepatic veins have nothing to do with this diagnosis. And so if you see this, if they say, hey, rule out veno-occlusive disease, and you see ascites, you see a really thick walled gallbladder, and here in this case, the hepatic artery does not look particularly sluggish, neither does the portal vein. You still are going to say these findings support the possibility of veno-occlusive disease in this patient. Unfortunately, and this is a series of things, this is the clinical note that I cut, and it says, hey, we want to get an ultrasound to rule out veno-occlusive disease. And we booted it because on ultrasound, the person just said, hey, looks like you've got gallbladder wall thickening and the Doppler was normal. Well, that didn't answer their question. That's not really what they were looking for. They went to the interventionalist who said, hey, there was a high pressure, and this is veno-occlusive disease. And in fact, that's what it was on the biopsy. So here's another case where if the question is rule out veno-occlusive disease, you don't even need to look at the hepatic veins. That's not what they're asking you to do. Look for ascites, look for a thickened wall. This wall is not particularly thick, but it is thick. The portal vein is patent. It's not particularly sluggish. The hepatic artery is open, but it's, the resistive index is a little high. This is marginally supportive of veno-occlusive disease, and I think you'll have to report it that way. This patient did fine without treatment, so probably didn't have the disease. So you're not going to be right all the time, but I want to make sure you know what you're looking for. So in conclusion, we've had a chance to do a variety of things, look at some tips, and make sure you understand some tricks. And I thank you for your attention.
Thank you so much, Dr. Patel. I mean, that was so good. Even a neuro guy feels slightly more comfortable reading tips. So I appreciate that.
Absolutely.
So again, thank you, Dr. Pellerito, Dr. Patel. You guys are amazing. Thanks to all who attended today, and we look forward to seeing you again on Thursday. And be well, everybody, please. Thanks, guys. Really appreciate it.